Thank you so much for the opportunity to present. I'm Kelly Huang, a first-year medical student. While radiation therapy has transformed the care of patients with cancer, a long-term complication is radiation-induced fibrosis, which is characterized by chronic ulceration, skin retraction, and impaired wound healing. Despite its prevalence in 30 to 70% of patients who undergo radiation, there are currently no effective strategies to treating radiation-induced fibrosis. A common strategy that has been utilized in the clinic is autologous fat grafting. However, it is limited by donor site availability, especially in patients who are losing weight. An emerging strategy has been the use of decellularized adipose matrices, or DAMs, which are off-the-shelf fillers prepared from discarded lipoaspirate, and they retain the macromolecular structure and growth factors present in fat that help with attenuating fibrosis. Therefore, in this study, we aim to evaluate DAMs and fat grafting in treating wounds that develop after radiation-induced fibrosis. For our methods, we took 30 female mice and treated them with fractionated radiation to the dorsal skin for a period of 12 days to mimic the treatment given to patients with breast cancer. After a period of 6 weeks to allow for the development of chronic radiation-induced fibrosis, we created full-thickness cutaneous wounds to the dorsal skin and treated it with either DAM, fat grafting, or a saline control. Also, for another 10 mice, we did not undergo any radiation and only created dorsal wounds to serve as a non-irradiated control. For our results, we saw that treatment with DAM and fat grafting improved tensile strength of the skin after post-operative day 21 compared to the irradiated saline group. We also saw that the tensile strength approached that of the non-irradiated control. Importantly, DAM and fat grafting demonstrated similar skin stiffness at post-operative day 21 to each other. We also evaluated vascularity at post-operative day 1, 7, 14, and 21, and saw that treatment with DAM and fat grafting improved vascularity, especially at the later time points. Next, we evaluated the rate of wound closure and also saw that DAM and fat grafting slightly improved wound healing rates. However, due to the variability of the data within each group, this precluded statistical significance. Lastly, we evaluated dermal thickness, which is a marker for the quality of the skin after wound healing, and saw that treatment with DAM and fat grafting improved dermal thickness compared to both controls. Also importantly, there were no statistically significant differences in dermal thickness between DAM and fat grafting. So in conclusion, DAM and fat grafting demonstrate comparable wound healing outcomes after radiation-induced fibrosis, such as skin stiffness, vascularity, and dermal thickness. Therefore, DAM could serve as a promising non-invasive strategy to treating wounds that develop after radiation-induced fibrosis, especially for patients where fat grafting is not an option. Some future directions include evaluating the molecular mechanisms of how DAMs impact wound healing, and also its effect on fibroblast subpopulations. It would also be interesting to optimize DAM therapy, such as by incorporating different growth factors that can help with enhancing its skin regenerative potential. Thank you so much for listening.